Good evening and welcome. Thank you so much for coming tonight. It's nice to see everyone out there. I'm Lisa Daziel. I'm Dean of the College of Pharmacy at Nova Southeastern University. First of all, I'd like to welcome all of you to our United Stand Symposium to learn more about the opioid crisis. I also want to say hello to our community who's watching us from Palm Beach, so hello to all of you on our stream. We do realize that the solution to this public health issue depends on all of us working in an interdisciplinary manner. And that includes healthcare professionals and first responders, our legal representatives, social behavioral practitioners, and the public. Coming from an oncology pharmacy background, I certainly recognize the need to find solutions that provide quality care for pain patients while limiting the potential for illicit use in all. I think you will find the discussion today illuminating, and we certainly appreciate you taking the time to join us. We cannot provide our educational symposiums without the support of our sponsors. Tonight, I'd like to give a sincere thank you to our presenting sponsor, Greenspoon Marder, our VIP, thank you. Our VIP reception sponsor, Cleveland Clinic, Florida. Our gold sponsors, the AIDS Healthcare Foundation, Apotex, the United Way of Broward County Commission on Substance Abuse. And our silver sponsors, the Caduceus International Publishing, Walgreens, Walters Kluwer, and Baptist Health South Florida. I'd also like to thank Dr. Scott Kjelson and Ms. Sharon Sullivan and her team for all of the work that they've done to put this together. Thank you to, thank you. Thank you to all of our panelists who are here with us tonight, our distinguished guests, including our elected officials who are in attendance today. It is very nice to see all of you here and see you in the audience, and we certainly appreciate your support. At this time, it is my pleasure to introduce Rebecca Bratner, Deputy Managing Shareholder of Greenspoon Marder, our presenting sponsor for this evening for a few opening remarks.
Good evening. During the reception, I was just remarking that this is like coming home for me. I'm a Nova Law School grad. My husband is a Nova Medical School grad. And both of our children are students at the university school here. So this is like being at home. My name is Rebecca Bratner, and I am the Deputy Managing Shareholder at Greenspoon Marder. On behalf of Jerry Greenspoon and the entire Greenspoon Marder team, I wanted to add my welcome to this important and what I believe will be a very informative and productive evening. It is no surprise to any of us here that our country is in the midst of an opioid epidemic. Opioid abuse knows no bounds, be it race, religion, or economic status. Each of us here tonight knows of someone who has suffered from opioid abuse, and we have a duty, a responsibility, to take the necessary action to raise awareness of and put an end to this crisis. NSU is an important partner in these efforts. The expansion of the undergraduate and graduate programs, together with the addition of the Center for Collaborative Research and the upcoming addition of the new hospital on this campus, are key additions to aid our community in fighting this disease. Through research, we can and will find alternatives to the use of opioids. As a law firm, we are committed to advocating for necessary changes in legislation at the local, state, and federal levels. We started our firm right here in Broward County and have been involved in this community for over 30 years. The business community has a responsibility to play an integral role alongside medical professionals, researchers, educational institutions, and our representatives in government to stop this epidemic and to encourage and fund the necessary research that will lead to alternatives to these dangerous drugs. On behalf of the firm, thank you for joining us this evening for this vital program.
Thank you, Rebecca. I do want to mention that if you see some of our students here with their white coats and the purple patches, they are pharmacy students who are here to learn and to be part of the next generation in making a difference as we move forward with not just the opioid crisis, but also, or the opioid epidemic, but also all of the other medications that, and illicit drugs that cause problems with our population. So we want them to learn early and be a part of making a difference as we move forward. They can also talk to you about a lot of the research that's being done in the College of Pharmacy, and we have some of our faculty, or at least one of our faculty members I saw somewhere, who's actually doing research on abuse deterrent medications. So we are very heavily committed in trying to make a difference in this as we move forward. At this point in time, I would like to introduce Senator Gary Farmer, who is a member of the Florida Senate, and he is going to give us also some opening remarks. Senator Farmer, thank you.
Thank you very much. I want to begin by thanking all of you for attending and participating in this panel discussion on such an important issue. I know that we're all here because we recognize that addressing the opioid epidemic that is ravaging our state and communities is an absolute necessity. The heartbreaking reality is that most of you in this room probably know someone whose life has been shattered or impacted because of an opioid addiction or overdose. In Florida, this crisis has hit us particularly hard. In 2015, there were 4,000 opioid-related deaths in our state. As a state that makes up 6% of our country's population, we account for 12% of the opioid-related deaths nationwide. Last year in Broward County alone, we had nearly 600 lives that were taken too soon as a result of opioid overdoses. This year, we are sadly expecting that number to grow. And just this morning, I was speaking with a colleague of mine, Senator Kevin Rader, who's been one of the more passionate advocates in our legislature seeking some opioid-related legislation and fixes, who shared with me that we are now averaging more opioid-related deaths per month than either automobile accidents or gun-related violence. To me, these are staggering numbers which should command our attention and call out for action. Every individual who struggles with addiction and therefore the possibility of an overdose has their own story. Those individuals have their own set of factors that ultimately put them at risk. I believe I'm correct in this number that I read, 75% of people with opioid-related addictions started out just as a pain patient who was in need of some sort of relief for pain. They weren't drug addicts. They aren't people seeking this for recreational use. It's legitimate medical use that then becomes addictive and spirals out of control. And this could be related to medical issues, circumstances in their personal life, or biology. As we try to address this country's opioid addiction issue, we need to come to terms with the fact that there is no silver bullet for this problem. And that's why it's so encouraging to see panels put together like the panels that are going to be discussed today, because we don't know what the answer is yet. But we've got dedicated individuals who are willing to spend their time working on this important issue to find those answers. Right now, a patient with chronic pain or other pain-inducing ailments is faced with very limited options. There aren't many alternatives out there. This has led to a seemingly inevitable prescription of highly addictive opioid-based medications. As a result, our medicine cabinets have become proliferated with powerful drugs with the dangerous effect or impact that I've just been discussing. I would be remiss if I did not take this opportunity to mention that with regard to one of those alternatives, today I filed a bill that I believe would help address some of these problems. Senate Bill 726 was filed today which would allow for the smoking of medical marijuana. I'm sure you are all aware that our Constitution was amended by 71% of the voters last year. But when a Constitution is amended via vote, it is then left for the legislature to implement that legislation. And our implementing legislation, sadly, did not allow for the smoking of medical marijuana, even though the constitutional amendment itself specifically said there will be no smoking in public places. The clear implication, of course, is that smoking in the privacy of your own home would become legal. We know that patients who can be served and receive the benefit of medical marijuana are different. They all react to different forms of ingestion of the drug. And so it is my hope that if we can pass this legislation to allow what the voters approved and allow for a common delivery method that is not controlled by the group that seeks to control most of that industry, it's going to help patients, and it's going to give physicians an option. Thank you. It is my hope that with the passage of this legislation, we can ensure that our medical professionals are equipped with a full range of options to treat their patients. And addressing this tragic reality of the opioid epidemic is not and should not be a partisan issue. This is evidenced by the fact that we have Democrats and Republicans in this room today seeking a solution to this epidemic. The addictions and overdose that are tearing apart our communities do not know party lines, and our solution should not either. The heavy cost of this crisis is one that must be borne together and is a problem that we must fix together as well. It's also absolutely critical to remember that when we are talking about those who are trapped in the snares of this gripping addiction, we understand that we're not dealing with a criminal problem, as I said before. These are mostly innocent patients who've been caught up seeking a remedy for their pain. And so we need to treat them with empathy and sympathy and provide for them all options that are available and properly address these issues that we're facing today. As I said before, there is no silver bullet that we can look to solve all the problems contributing to this epidemic. That being said, today we have a fantastic, diverse panel of medical professionals, policymakers, patients, and community leaders and organizations who've dealt with various aspects of this crisis, who are here to help us dive into both the crisis we're facing and the ways that we can solve it. This exchange of ideas and experiences should be beneficial. I know it will be beneficial, and hopefully we can leave this event together with a better grasp on what needs to be done and with some ideas for solutions for the problem. I want to give, again, great thanks to Southeastern University for leading in this area, and especially Scott Kjelson for moderating this. I remember Scott visiting me one of the first weeks I was in Tallahassee last year. And like many, I was somewhat aware of the opioid crisis and addiction problem, but I have to say I was ignorant as to its true breadth and impact and scope. And Scott, you've helped educate me a lot, so I really appreciate your advocacy in this work. I want to thank Greenspoon Marder for sponsoring, all of our other sponsors, Cleveland Clinic and the United Way and the healthcare field, and all the others who are here to help us find answers. And thank you to our panel of dedicated and talented healthcare professionals, community leaders, and others for dedicating and contributing your time, volunteering to be here to help us solve this problem. Together, we can solve this problem. We owe it to ourselves, we owe it to our community, and we owe it to the people who are sadly the victims of this opioid epidemic. So thank you very much for being here. Thank you for your attention. We look forward to a lively panel discussion, and we're going to come out of here more educated and with concrete ideas as to what we're going to do to solve this problem. Thank you very much.
And it is now my pleasure to introduce Dr. Scott Kjelson, who has really been the force behind this symposium, and it is due to his efforts that we are here tonight, so thank you. He has more energy than I thought possible in any one individual. So with sincere thanks for your commitment to solving the opioid epidemic, I will turn the microphone over to you. Dr. Kjelson will serve as our moderator for the panels tonight. Thank you very much for your attention.
Good evening, ladies and gentlemen. And those watching from distance, I really do appreciate every one of you. It's an honor to be here tonight. It's an honor to be able to take on public health issues as a collective group. And what I've been saying from the start is we need an all-hands-on-deck approach, and we're seeing that right here. It's very important to me to have this discussion because many times we have discussions about policy and health problems that exist in our communities, and the main part that we miss out on is bringing the communities together. And this is why I wanted to have an evening event and make sure that our providers are here, that our law enforcement are here, that individuals that care, that are being affected, which is each and every one of us in some form or shape. And it's important for us, again, to come and voice that. So with no further time wasted, I'm going to introduce our policy panel tonight. If you could hold your applause till after all names and individuals come up, I'd appreciate that. First, I'm going to start with Representative Nicholas Duran. Nicholas Duran, if he's actually running a little bit late, I'm going to introduce Kathleen Cannon, CEO and President of the United Way of Broward County. Representative George Moritas, member of the Florida House of Representatives for Broward County. And Special Agent Jonathan White, DEA agent and the regional director for the 360-degree program that the DEA has to offer. So if we can, give him a round of applause. Again, Representative Duran is running a little bit late, and I do apologize for that, but we're going to go ahead and start with our panel. Agent White, I'd start with you if we can, and I'm actually going to start talking a little bit about the recommendations made by the DEA towards prescribing, how you think prescribers in general took that coming from an enforcement agency, and what type of resistance have you seen when it comes to reaching providers to working with you?
All right. Well, Scott, thank you for inviting me here today. It's an honor to be here. So let me first start by saying the DEA does not tell, and we know we should not be in the business of telling legitimate patients, legitimate physicians and pharmacists how to treat their legitimate patients. Let me just say the obvious, that most DEA employees have not gone to medical school or pharmacy school. We are investigators and regulators. That's what we do. With that said, we do frequently point physicians and DEA registrants to the prescribing advice that's recommended by the CDC. The guidelines from the CDC are fairly comprehensive, but essentially the CDC recommends that physicians start low and go slow when it comes to treating pain. So that's where we point people to. We also want people, when we talk to our physicians, we want them to know their patients' history, use available resources like the DEA and the PDMP to help them when necessary. This will help in identifying doctor shopping and so forth. And of course, focus on individualized patient care and treatment. That's the advice that we generally give. Now, how, in regards to coming from an enforcement agency, you know, we hope that physicians and pharmacists and DEA registrants don't just look at us as an enforcement agency. We hope that they look at us as a partner and a resource available to them. Again, we do not want to be in the business of telling a medically trained physician how to treat their patients, but we do want to be a partner and an available resource to them.
Thank you so much. I do appreciate that. And you guys have been doing a great job with the 360 program, which we will discuss as well. Representative Moritas, you're on the Appropriations Committee, and many times we see things that come across your table, or you'll see things that come across your table that taxpayers don't realize that is coming right out of their taxes that we do pay for, and sometimes we turn an eye to things like that, and I don't think really people understand when somebody goes to the hospital, for instance, for an overdose, that many times insurance companies don't pay for that overdose, and many times those overdoses are not from illicit drug use, but just from not using the drug properly. So can you tell us a little bit how these things impact us on a fiscal level between the state and how we can prevent them from happening to begin with?
Well, thank you, Scott. I want to, again, thank you and thank Nova Southeastern for hosting this great forum and for everyone showing up. And it does make a big difference with policymakers that you actually get actively involved, and we'll talk about that as we go forward. But, and I think Senator Farmer did an excellent job of laying out what a crisis this is. And so I don't want to sort of focus too much on numbers. I'll put out some numbers that are there, but you know, whether this was causing anything or not to the taxpayers, we should still be doing something about it. So I want to be clear about that, and we are going to do something more about that as we go through the discussion tonight and the next legislative session. But specifically, the Palm Beach Post had done a study. It's very hard, obviously, to put a finger on exactly how much is being spent on something like this. But, of course, the state and federal government spend a tremendous amount of money on Medicaid, which is the health insurance, or the health care, rather, for the poor, and uninsured care. You know, the statistics they put out from their study were, as recently as 2015, over $1 billion related to the heroin epidemic for hospital charges, $2 billion for hospital charges based on Medicaid, where Medicaid's a primary provider, $800 million were babies that are born addicted. You know, I guess it's a true crisis, and it is costing a lot of money, but more significantly, it's costing a lot of lives.
Right, absolutely. And Kathleen, with the United Way, you guys have been great at being able to take the legislation that's proposed and implement it into the community. Can you tell us a little bit about that and what your success has been with working with the legislators?
So I want to commend the audience. There's so many people here from all different types of representatives, as well as students and Nova, and it is such a group effort to tackle this issue. You know, special agent representatives, we've got government, we've got universities, so it really is a group effort. So, but legislation is so important, and United Way and all of us at this table and everyone really advocating for some very specific issues that will change what we're doing, and it will change the crisis. We always have to come at this crisis like a multimodal level. Can't just do it from prevention or from legislation. There's multiple ways. So super important is the prescription drug monitoring program. Now, many physicians will report when somebody is being prescribed opiates, but pharmacies are terrific at it. You guys do it, but not everybody does it. If we could get everybody doing that monitoring program, people would know that somebody was drug shopping or somebody was overusing, and we could stop that. It could be transparency. It is really an easy way for us as a community to help monitor this. Another very important, I know we're going to talk about it a little bit more, is the controlled prescribing guidelines. Too often, I'll just use the example of my son, who's 19, but he had his wisdom teeth out when he was 16. He came home with a 30-day prescription for oxycodone. So, but he doesn't need that. So what we're really advocating for is a 3-day prescription for acute pain. This is not monitoring people who have cancer and chronic pain. This is for acute pain. If we could reduce those prescriptions to maybe a 3-day supply as opposed to a 10-day or a 30-day, think about how the cycle of addiction that we could stop by doing that. So we're advocating heavily with all of you for that as well. And I'll just touch quickly on funding. Florida, unfortunately, is funded the 49th out of 50 states for behavioral health. So we're almost the lowest in funding to fight behavioral health, mental health, substance abuse. So we're really asking and looking for legislation to see if we could increase funding for prevention, so we stop the addiction from happening, intervention, where we can intervene quickly while it's going on, and treatment. If somebody is addicted, getting them into treatment. If we could work on those 3 aspects, think of what we could do. Think about the lives that we could save. So we are really doubled down on those 3 areas with all of you and everybody here. So it's really vital and important that we work on the public policy piece, because it's almost the groundwork for stopping the addiction. So we are proud of everybody so much, and you've been so great with advocating with us. So Gary Farmer, same thing, Senator Farmer, thank you.
Well, and I appreciate you guys as well. I think a lot of people think of the United Way not so much in the area of behavioral health or illicit drugs, and I think you guys have done a great job. It's very important for, especially when things like the DEA come out with a 20% reduction in manufacturing. Mm-hmm. One of the biggest things is that when individuals in the community hear this type of announcement, the first thing they think about is that the bad guys are going to get the pills, and the people, the compassion that we need to have for these individuals that really, truly need these medications are not going to have access to them. So can you explain a little bit about that?
Yes, it is true. For 2018, the DEA has recommended that there be a reduction in controlled substances. But it's important to, remember that this decision was not made in a vacuum. And we have to think about this in the context of our current opioid-related crisis that we're enduring and trying to address right now. The DEA always emphasizes a closed system of distribution, all the way from the manufacturer, the distributor, the prescriber, dispenser, and the end user. And whenever that system breaks down, that's what we call diversion. Whenever legitimate legal medications are diverted, that's when medicine is diverted illegally and is no longer available for legitimate patients. And that's why we're so staunch in trying to maintain that closed circuit of distribution. So, that's basically, what I would say to that is, context matters, and in the context that we're living in today, we have to reduce the amount of pills that are out there. We're just seeing way too much diversion. But we do, listen, the patient access concern, that's a serious concern. We don't take that lightly. We understand, we do not want to do anything that's going to impact the availability of pain medication for legitimate patients. But it's a delicate call, but we felt that, based on a whole host of factors, they felt it was necessary to call for the reduction.
And I appreciate that. You and legislation, we have a great state prosecutor here in the state, Dave Ehrenberg, which is not here with us tonight, but you guys have been dealing with the sober home issues. And Representative Morales, I know you were working on that as well. And I think a lot of people don't understand the issue with the sober homes to begin with, why there's fraudulent sober homes allowed to be out there to start. And people are really concerned that if they do go actually seek this treatment or seek these locations to be safe, that they'll fall right back in. If you can just talk to us a little bit about that, how it affects the state, and also the capacity, because I understand that right now we can't even accreditate these sober homes fast enough because there's only a small employee ratio to handle these certifications. Okay,
well, thank you. Good question. First of all, last year, the sober homes, I first came into this as more of like a nuisance thing in the communities, in other words, it makes these neighborhoods terrible because, the problems that go on with them. But really, I've been educated by United Way and others, the providers, that really what's actually even more of a tragedy is that people are actually being put into these programs that aren't really well run. Mm-hmm. They're not getting treatment. They're not being saved. And yet we have these wonderful facilities like Bark and some others, Henderson, in our area with legitimate medical providers that actually have great results. And so I think from the state standpoint, there's a couple things. One, last year, Representative Hager from Boca Raton, who's been a real champion on this issue, sponsored a bill, which many of us co-sponsored, to basically crack down on the fraudulent marketing and the patient brokering. That was kind of the big emphasis. Try to sort of stop the flow, and then also look more into the people giving the services, do more background checks. And that came out of a task force in Palm Beach County, and I think that's a great start. And again, former State Senator Ehrenberg helping with that. The next step perhaps would be to do more regulation of the facilities themselves. There's a little bit of reluctance on that just because, again, it requires sort of almost ramping up another state agency, funding it, and there's just always reluctance to do that. I think, from our standpoint, we want to see the money go to, like Kathleen just mentioned, education, like Mr. White's saying, keep the drugs from getting into the hands of people, lower the prescription amounts, and then focus on the treatment and diverting a lot of resources into running around at the sober homes. We just, we want to make sure they're not getting money, but, setting up a whole other state agency might divert a lot of resources from the effort.
Absolutely. Kathleen, we started this event based on an idea that came from a community response team that the United Way hosts. That's actually where I met Agent White as well. You guys have been very great at getting these, like we said before, policies, regulations that come up into the hands and the voices of many leaders in the community. So if you can, describe the community response team a little bit and how those type of committees do bring everybody to the table.
Sure, so thanks. So the community response team was kind of born from community advocates. We employ what we call a collective impact model, meaning really working together, putting one course of action, one strategy, one business plan, in a sense, in place, and how many partners can come together and work on that. And the community response team was really formed because of the Flocka epidemic, because it was so out of control here in Broward. How can we come together? How can we solve? And now that has moved into just the community response team and now tackling the opiate addiction. Our chair is BSO, is Dave Sharf. He is here, and he's a magnificent chair, and there's many community members of the team that are here, and it's made up of federal agents, local law enforcement, our judges, physicians, pharmacists, community advocates, parents, the school system. It's, again, about tackling a social issue like this in a multimodal way, not just one aspect of it. So you can't just come at it with only reducing prescriptions. You can't just come at it by educating only children. There are so many levels that we can do and educate and steward this message that we can really make a real difference and move the needle on this addiction. So it really is about kind of coming together. Nova has stepped up for us. Heather Davidson, I have to shout out the staff member for United Way. She's marvelous at bringing folks together. So United Way, really our role is convening. It's bringing folks together and setting that agenda together. And we did an opiate action plan that has been distributed to many, and then we have these toolkits that have gone into the guidance counselors for all of our schools. So again, it's about trying to get the message out and working together. And we're gonna ask everyone in the audience today if you'll steward this message after you leave here. Some of the nuggets that you have, if you could help educate your neighbors, your parents, your cousins, the more we can talk about this and educate our community, the more this word will spread and people will see that this is a crisis and we're losing wonderful people and families are being shattered because of this. But we can prevent it and we can prevent that together. So really that's the United Way role, is the convening piece. You guys are really the experts making it happen.
Scott, if I could just piggyback on that, well said. And it is, you know, one of the reasons the DEA is involved in this action committee is we recognize how important it is to get out in front of this problem. This year, 1.4 million people will use opioids for the first time non-medically for recreational use. 1.4 million people, many of them in their teens and in their 20s. That's a huge problem. That's something that we can get out in front of. 41% of teenagers believe that opioids are not as dangerous as methamphetamine, cocaine, heroin, other hard drugs that they find on the street. This is what they think. We go to schools all the time and we talk to the kids. We hear it from them. And of course, we try to correct that myth. We have to crush those myths. We have to reduce those numbers. It's better to deal with it on the front end than on the tail end. And so that's why we're involved in these types of outreach, programs and coalitions.
Thank you. And one amazing thing we have here in Broward, which all of you are included in, is the centralized holding units, and how Broward and many other counties in the state are looking at this as an opportunity to not just be law enforcement, putting people in jail when there is a legitimate issue going on. We now have a centralized unit here, and a lot of that behavioral health and mental health and drug abuse is taken into consideration. And like I said, not just leaving individuals in jail where, again, Representative Moritas, our taxpayer dollars go to. What are your thoughts on this state's approach, and how do we ensure sustainability of this? And what advice would you give to your successor coming in to ensure that, again, these programs last and are preventative?
No, I spent a lot of time talking, frankly, in preparation for this meeting, and I want to thank, again, just the encouragement to get involved more in this. And, first of all, there is a fair amount of money coming down for treatment. I mean, I think we know that the $54 million that the feds have approved, that the governor's advocating for $50 million. I would say the piece that's lacking, at least from when I'm talking to our leadership, is, what exactly is the plan to do this and how to use this money effectively. And I'm going to say that, again, you asked my advice. My advice is to get involved. If you think you have a part of this solution, I can tell you right now, I'm not a doctor, just like our DEA agent said, I'm not a doctor, I'm not a treatment professional. We get a lot of help from Heather and Kathleen and many others in the community that come up and advocate for these things, but it's very important for you all to get out to your legislators and say, these are actual solutions that can help. If you see the budget being crafted and a lot of stuff's being left out that you think is important, you need to speak up, because I've changed my vote, I've changed my position on things just because someone came to me directly. The most effective thing, it's painful, is the one-on-one meeting. If you can't do that, a handwritten note. If you can't do that, a phone call. But realize, or working through large groups like United Way and others. So I would say that the state is going to do a lot this year. The governor's made that very clear. Representative Boyd, who's the chair of the Regulated Affairs Committee, is sponsoring House Bill 21, which I'm going to be co-sponsoring. That will, again, talk about some of the PDM, the prescription data managing base, to reduce the, get more people looking to see who are the addicts, reducing down to 3 days or 7 days the amount of prescription drugs you can get, like these dangerous opioids. And then the money piece, I think, is still being formulated. I just have to be frank. We're getting ready to go into legislative session in January, and this is the time where we want to see, where is this money going to go? What's the best bang for the buck? And it's not just treatment. It's going to be education, intervention, like Kathleen said, and treatment's a big piece of it, too. So from my standpoint, I want to see more done to get the bigger facilities that are actually doing the treatment and get the treatment professionals the resources to fight this thing and not have it diverted into the sober homes and the other inadequate providers.
And I want to share because, again, like a call to action here today, there'll be something that everybody can do. And I know some people, if you don't know your legislator personally, you can look that up. But honestly, they listen. They really do. And they want to make decisions based on fact and our community and have our backs. So we've had so many conversations and truly listen. So that is something that everybody can do here. Is if you can't go visit, you can make a phone call. You could do an email. That kinds of repetitive advocacy matters and makes a difference. So I'm going to ask you guys to continue to please do that. If you've not done it, I would ask you to do that. And you can attest to that folks really do listen.
Absolutely.
So,
Representative Moratis, you had mentioned about House Bill 21, and I know that's Senate Bill 8 for everybody else. And if you can explain this, because the governor has been going around the state talking about this. I know Representative Duran, who's not here right now, had proposed this type of legislation in the past. CDC's recommendations follow along this. And one of the things that we do hear about is because it's limiting the days amount that a patient can receive medications, opioids for, there's been a big scare about chronic care patients. Can you just clarify the difference between the chronic care and acute care with that legislation? Because from my understanding, it's focused more on the acute side.
It is more focused on the acute side because that's, again, like we said, 75% of people get into these addictions through what was a legitimate prescription or stealing it from somebody who has a legitimate prescription. And so we really feel like controlling in the acute sense. Obviously, the chronic patient that needs it, and we're all in agreement, you need to get something. This tends to be a dangerous alternative, but it is a legitimate legal alternative to pain management. That's not what we're trying to address. We're trying to address the person that comes out of surgery, may need a day or two of it, and we're going to limit that to 3 days, basically. There would be another day, a 7-day limit, and this is just being proposed now. But this bill was actually the governor had a kind of a task force on it. These are the recommendations out of it. The House is taking it, the Senate is taking it. We fully expect this bill to move through and be passed fairly soon into the session. But the focus is on acute care. There will be a 7-day limit if it's medically necessary and documented that they need it and those types of things. So there is some flexibility in it, but we're really trying to keep it to the 3 days when you really, in most cases, I've had a few surgeries, sad to say, but I know it's the first day or two that tend to be the worst, and then after that you kind of start to emerge out of it.
and let me just say too, so again, being stewards that are sitting in the audience, the proponents or opponents, the opponents of this are saying, oh my goodness, you can't limit people's prescription. You can't limit their pain. People are in pain. This is not about taking away legitimate pain medicine. This is reducing the amount that is given to people. It's been proven over and over that there is too many, the prescriptions are too large, and young kids are stealing that from their grandparents' medicine cabinet or their parents' medicine cabinet. It happens all the time. So if we can give somebody a 3-day prescription as opposed to a 30-day, they won't be able to steal it from their grandparents or anything. So we're going to ask you to steward that message when people come back and say, oh my gosh, this is unconstitutional, you can't do this. It's really about limiting, and we don't want anyone to suffer that's in legitimate pain, nobody. And there are methods to take care of that pain. So let's not confuse those two issues. I want to make sure we really understand that.
Absolutely. Well, since the elephant's been in the room for a while now, and I got a smile on a face of our panelist, he knows what I'm about to ask him.
Here it comes.
He knows. We all know it. I'm actually wondering, and I think everybody in this room is wondering, about the response to the 60 Minutes episode from former DEA agent speaking about how a bill was passed to reduce your capability of actually doing your job. If you can, just give us a little bit about that.
Well, that was an interesting segment, very, clearly raised some important questions. And, I know that gentleman. He's a passionate man, and he wants to make a difference in our community. It does appear that after the 60 Minutes episode, there are a lot of questions being asked of our diversion program and the effectiveness of our program. And frankly, I think that's a good thing. There's also an ongoing OIG investigation that's currently conducting a review of our DEA diversion program. We embrace that. I and other people in the DEA, we understand that government needs to be transparent, and it needs to be effective, and it needs to be, held to a certain standard. So if, the result of these inquiries and these audits into our diversion program makes us a stronger agency and makes our program better, then I will applaud it. That'll be better for our country and better for our community. But certainly, there's questions that need to be asked, answers that need to be given, and that's we embrace that. We're okay with it.
Well, I could vouch for the DEA and my experience with you guys. It's been nothing but transparency and the eagerness to reach out, so I commend you guys for that as well. Representative Moritas, another elephant in the room. So there's been data in states that have implemented medical marijuana that have shown a reduction in opioid overdoses and opioid deaths. Recently, the NIH received funding to do a long-term study of use of marijuana associated with chronic pain. And I'm actually glad Representative Duran's here, so he could actually talk about this as well. So just to reiterate, there's an elephant in the room. There's many states that have implemented medical marijuana have shown a reduction in opioid overdoses and deaths from opioids. I'm wondering, in Florida, what types of discussions are being held around this claim, and are we leaving any room to focus on this industry, the medical marijuana industry, as an alternative, and are we looking at other alternative methods? That's for both of you.
Do I get to answer that?
Both of you. Have fun.
I have not been the biggest champion of medical marijuana, but I will first say that may be a silver lining in this medical marijuana movement, is that it may reduce the opioid addictions and deaths. I mean, that's probably the one positive thing I can see. We actually have relatives that have sadly gone through addictions with opioids, and this is an alternative for them. So, what always troubles me about it is that it's not something that the medical community seems to embrace in any kind of scientific manner in terms of doing trials and those sorts of things. I know there's a lot of explanations for that, but I just don't, a part of me just feels that if this is a great idea, at some point it should be medically proven. And maybe that's just because there's resistance in a lot of different fronts, but, morphine has a lot of problems too, and that's got a legitimate use, and this, for some reason, the medical community just hasn't embraced it. So I never want to feel like I'm sitting on a super medical panel when I'm in the legislature. But, in response to what the voters wanted, we did pass a medical marijuana bill last year to allow for people to do it with the THC and those sorts of things. And so, part of that will be to do some trials, have the University of Florida do some trials and try to do it. We'll just have to see where that goes. I would just say, in response to my dear friend, Senator Farmer, the smoking thing, as I understand it, because you can't control the dosages through the inhalations and those sorts of things, it's not been, again, embraced by the medical community as a preferred method of doing it. So, again, there's a lot of things out there. Perhaps it's promising. I don't want to be negative because, again, I've got relatives that have benefited from it in terms of pain treatment. So I'm certainly being more open-minded than I used to be about it.
Absolutely. Thank you. Representative
Yeah, thank you. And My apologies for being late and showing up to the party late. Yeah, I think the voters overwhelmingly passed medical marijuana. And in our state, that meant that we as a state have chosen to embrace marijuana for medical reasons and purposes. So when you look at, where we stand right now with this opioid epidemic, and some folks who say this may be the right alternative, that's absolutely correct. I think we should be sort of looking at that. Now, I think a state has began to take steps in investing in us as a state to say, on those studies. And I think you said it right, University of Florida has begun to do a study there. But we need to do a full concerted effort. And I think that is a part of how do we take on this opioid epidemic, is for us to look at alternatives, ways to treat chronic pain and pain in general. One of our colleagues in the House, Representative Carlos Guillermo Smith, always says, "Show me the data that shows that somebody's overdosed on marijuana." And whenever we started talking about the opioid epidemic or any issues or bills or policies related to it, I think it's a good point to be made, to sort of a good jumping off point. But we're dealing with a massive issue, and if there are other alternatives, and our state said, let's follow it, let's take this on, then let's do it. And I think that's what we should be putting a lot of our concerted efforts into.
Well, Representative Duran, following up with that, you've been a huge champion for the needle exchange program down in Miami-Dade. You've worked with Dr. Tukes out of the University of Miami, and we know from data that implementing these type of programs reduce other issues like hepatitis and HIV. It also increases a point of contact for our providers to have with somebody that's using illicit drugs that would never come through a pharmacy or physician's office. Can you tell us a little bit about that and what inspired you to actually help with that program to get it off the ground?
Sure. So for me, addiction has been a part of my family. Like, I have a brother-in-law who lost his life to opioid epidemic. And for him, he had struggled for 7 years. He was 7 years clean, but before that, he had a struggle of his own to try to get clean. Had to go into rehab a few times, and it costed a lot of money, a lot of heartache and emotion by the entire family. So for me, what we saw and what we realized quickly is that access to those who can help you, or at least direct you towards a path towards becoming clean or helping you find a way out of this disease, you have to be, most of the time you're lucky. You're lucky in where you live, who you're born, what family you're born in. And so if we can take it on and think about it as that, right, change the culture of addiction, that what we're looking to do is create routes and pathways that we can allow folks to get that help. That is simply just one of those ways. It's another smart, pragmatic way to open a door for folks who are using needles to get access to the help. And that's their first touching point of somebody who cares and somebody who's going to help walk them through at a time where they're weak and they need a lot of help.
Well, I can definitely tell you have another person on your team, and I'll be a champion for any of these programs that you put forth. So thank you. Final question before we take questions from the audience and Twitter. Agent White, you know I love all your efforts and everything that we've worked on with the community response team. One of the biggest things for me, and we discussed it a little bit, was the 360 program. Please explain this and the initiative that the DA has taken, because I think in the minds of many, it's all about law enforcement and was not ran correctly in many minds. So if you can, please clarify.
Yes, DEA 360 is our current strategy to address the opioid crisis that we're dealing with. And there's 3 pillars to that strategy. There's law enforcement, which is our enforcement operations. There's diversion control, which is the regulatory oversight component. And there's the community outreach component. It's a holistic strategy. We partner with other federal, state, and local agencies, tribal groups. We also partner with private organizations like United Way and many of the recovery homes and the recovery groups that are in the in the community. So we just we realize that we cannot we cannot arrest our way out of this. Granted, some people do need to get arrested, but we know we can't arrest our way out of this, and that we need to be part of a bigger solution. We are the Drug Enforcement Administration. That's our middle name, enforcement, so that's always going to be a really big component for us, but we're not ignoring the community outreach part and the diversion control aspect of it.
Well, I think it's better to see you with a handshake than with handcuffs, right?
Yeah, absolutely.
Well, one of the questions, I'm glad that made you guys laugh. One of the questions that we had from Twitter was that a 3-day plan for prescribers and opioids seemed a bit too restrictive. Representative Duran, you championed this legislation, and the governor has definitely gone around and used your words, so I could hear it through his voice. I want to ask you, what are your thoughts on that when somebody says that 3 days is too restrictive?
Yeah, so last year when we started, we introduced the bill on the House floor, we passed it, we had a very serious discussion and debate about creating a limit for the first time in this state, and it would be initial 5 days for the initial prescription of opioids. And we had a very vigorous debate. We had some doctors stand up in favor of it. In fact, the bill, as it was before, we amended it to include that in there, and that was somebody who was a member of the House, Representative Carrie Pigman, who is a doctor, an emergency room physician, who came to me and said, look, we can put something like this in here and really have a conversation and really spark the debate this go-around. And we did. And we had a full, hearty debate on that floor about that. And the reality of it is when you look at the data, right, I always say follow the numbers and look at the numbers. And when you look at the Prescription Drug Monitoring Program reports and you see that 12 million of the 36 million prescriptions that were doled out were for opioids, and when you look at the Prescription Drug Monitoring Program only being used by 22% of doctors, you kind of realize that we have something on our hands. We have a monster in our hands, even with all the bills and legislation that passed before. So the idea was we need to stop it, and this was just one of the ways, and the CDC had come out with a pretty comprehensive and persuasive report that said after the first 7 days could be the determining factor of whether or not that person is using opioids a year later and long-term use. So that was the heart and genesis of the bill. It was with that report when I saw it there, and then I saw that a few other states had to begin to adopt something like that, where it was raging in their states and their communities. So that's why we put it into place. The 3 days, I think it's 3 days, and really the bill that's put into place right now, it's in its infancy. I think that they drafted it 121 pages long. It has for acute pain, and what they're doing is they're breaking out this new sort of definition of acute pain and expanding it out from what chronic pain is. And so they're taking a pretty careful step to it, but there's a lot to be discussed. There's a lot to sort of look through on that.
We have microphones if anybody wants to ask a few questions. Just kind of going off of what you had just mentioned about the PDMP, I think one of the biggest issues was, and on the physician side, and we're going to have a medical panel, so we'll discuss this a little bit more, but was the concept of the PDMP not actually working with the health record systems. So in a specialty area, it was very hard to be at a fast pace with your patients and then switch over to put this information in voluntarily. So I'm very happy to hear that you guys are working with the experts in the area. And I think, Representative Morales, you mentioned that earlier. We're not, many times we're not the experts in the area, and it's our job to reach out and ensure that we work with them. Questions from the audience? Yes, sir.
Hi. Oh, I don't think it's on. I could speak loud. Hello? Oh. I just wanted to, this is for Agent Snow. I just wanted to, if you could explain or elaborate more about the contribution of wholesalers and pharmaceutical industries to the opioid crisis.
Expand on the contribution of wholesalers and distributors?
Wholesalers, distributors, and pharmaceutical companies to the opioid crisis.
Do you mean the contribution to the opioid epidemic?
Yeah,
Okay.
how they're worsening it.
Well, that's, I don't want to broad brush the whole industry. We do need to partner with them better. We have some, active conversations and some energetic conversations with industry on a regular basis, but we listen to each other. And what we want to emphasize is best practices or some smart practices, because, that's, and they want to do the same, but they're trying to be part of the solution as well. We do have concerns about the amount of pills that are being produced. Sometimes, when we have conversations with them, we'll have a conversation if we believe there's too much product being sent to a certain town. A town of 400 people shouldn't be getting, and this is an exaggerated example, a town of 400 people shouldn't be getting the same amount of pills that a surgical center in New York City gets. So, when we see things like that, that's when we'll start to engage with those manufacturers and those distributors and so forth. And we continually engage with them to try to make sure, I talked about that closed circuit of distribution. We want to make sure that, their practices are within the confines and the requirements established by the CSA. So their security requirements, because we want to make sure we're preventing any type of diversion from their facilities. But I'm not going to put this all on them. I mean, we do have a large demand. It's just, they have a role to play in the solution just like we do.
Thank you. Next question.
Yeah. I'm Dr. Can you hear me?
Yes.
Okay, great. I'm Dr. Wolowich. I'm a professor here at Nova Southeastern College of Pharmacy. And I just taught substance abuse this morning to our P3s, and some of them are here in the audience. And I do have a couple of bones to pick with the industry. First of all, America is one of 2 countries in the world that allow direct-to-consumer advertising of prescription drugs. There was a study published in JAMA last year that says the placebo response rate in America has gone up so high because of direct-to-consumer advertising. Big Pharma is having a hard time coming up with new analgesics because they can't prove they're any better than a placebo in this country.
Wow.
Okay, there's one problem. Second problem, when Purdue Pharma started making OxyContin back in 1990, they knew how long that drug would last. They knew it would not last 12 hours, and that is a prescription for addiction. OxyContin is a gateway drug. And Big Pharma needs to be held accountable for stuff like this because the FDA is not doing their job, in my opinion. They should be stepping in and at least looking at the marketing to the public of these medications. Thank you.
Thank you.
We only have time for one more question. I do apologize.
Sorry.
No, go ahead.
My name is Rick Riccardi. I'm a person in long-term recovery, and that means I haven't had a drink or drug in 23 years, and I'm in the middle of this. Thanks. You talked about we're finally addressing the issue we've been working with for years, and you talked about prevention and education and treatment. And we see that the world is now focused on getting this done. But there's a piece left since there's about, what are we talking about, 20 million people who are in need of recovery right now in the United States. And treatment is a 30-day, 60-day deal, which is established because that's what the insurance companies will pay for, and those without insurance are resigned to go into the barks and stuff and can't get in. But this is a chronic disease, and statistics show that you don't stay sober. You got a 15% chance of staying sober after 5 years. So between those 30 days and the 5-year period where your chances are good you're not going to relapse, the only solution that we've ever had is sober homes. And we're talking about sober homes like they're no good. And my point is that we've had over 3,000 people come through our recovery residences. Most of them stay sober, And yet there's no indication of what you're going to do after those 30 or 60 days of treatment, except just put people back out where they belong. Why don't we include sober homes in the solution rather than keep blaming it as a problem?
I would say it's because there's so wide array of the treatment you get in a sober home. I mean, there's clearly great sober homes or treatment facilities, and there's clearly ones that have no business doing it. And what we're finding is there's a huge volume of people that have no business doing it, and they're making it a problem. And they're diverting people from
Excuse
really
me,
getting
but they're
the-
not sober homes. If they're not keeping people sober, they're not sober homes. They're allowing people to use drugs and alcohol on their premises. That means they're not sober homes.
Right, and we want to start
Okay.
to distinguish between real sober homes and not real sober homes. People are being taken advantage of. So we can look at that for the next panel, for sure. We're supportive of folks who are assisting people in their recovery. I worked in Delray Beach in addiction with wonderful sober homes. It was the only way that I could keep my clients sober. But let's look to make sure that others that are not established and not really running good sober homes are not taking advantage. I've seen it over and over. They're taking advantage of people, their money, and allowing them to use drugs and then kicking them out on the street. So thank you guys for running good ones. But we appreciate that you guys are running good ones.
Thank you, guys. I really do appreciate it. Ladies and gentlemen, our policy panel, thank you guys so much. Thank you. Thank you all for joining us on the medical panel. I really do appreciate it. Dr. Massaros, Dr. Lynches, Dr. Swartzon, and Dr. Mai, thank you. Dr. Lynches, I'm going to start with you tonight. We really do appreciate you being here. The FMA, the Florida Medical Association, and FOMA, the Florida Osteopathic Medical Association, have been working diligently with the governor, the Surgeon General, and various boards to ensure best practice is met. Can you tell us what specific initiatives you find currently in place that are creating the best outcome for the opioid epidemic we face?
So thank you for having me this evening. I appreciate the opportunity to speak on behalf of Florida's physicians. There are a number of initiatives that have been underway for some time. For example, on the osteopathic side, there's a state-mandated CME class that we take called Federal and State Rules Governing the Prescription of Controlled Substances. Having given that talk in the past, I do include opiates in that, even before the crisis seemed to generate the angst that it has currently. Several weeks ago, the Florida Medical Association held an opioid summit that was incredibly well attended. In fact, the governor was there, as you know. The Surgeon General Celeste Phillip was there, as well as the president of the Florida Medical Association. And in addition to that, both organizations work diligently in working with the legislators in an effort to try to craft meaningful legislation. And I'll just take one moment, since we heard from legislators. I would like to underscore the fact that there really is no one answer to this. So every action has a reaction. So if the DEA limits the number of controlled substances that are flooding the U.S. market, there will be someone who will suffer some adverse consequence from doing that. If we limit the number of days a prescription for controlled substance can be written to 3 days, there will be people that will suffer. I mean, this is the basis of a society, right? The greater good necessarily has to outweigh the collateral damage. But don't fool yourself into thinking that people will somehow, with the passage of a law that's intended to be applied unilaterally across the state to every patient who has acute pain, will somehow solve the opioid crisis. That's simply, you're placing too much faith in the application of that. So both organizations are pleased to work with the legislature in crafting some flexibility in that. In fact, earlier this year, there was a JAMA article that came out that identified the variation in pain associated with different surgical procedures, and not all of them, their pain goes away magically at 72-hour mark. So it's encouraged that there is some flexibility. We do know that the data, as was mentioned before by Representative Duran, that the CDC uses, the breakpoints are 7 days and 30 days. So if you're on a prescription opiate, past that point in time, then your chance of being addicted to that increases at the 1 and 3 year mark. And I'll just close by saying that we do know that opiates have no safe, unaddictive dose. That any dose of an opiate, thank you. Any dose of an opiate has addiction potential. In fact, all of us in this room have the potential to be addicted to opiates. That does not mean, however, that all of us will be, but it means that there is that potential. So I appreciate the opportunity to speak to you guys tonight. Thank you.
Thank you so much. Dr. Massaros, the Board of Pharmacy has been working diligently with the FMA and other boards to ensure that we tackle this correctly. We know that we've also been seeing the Board of Pharmacy work with the DEA, as well as seeing the DEA work with the FMA through all these multiple meetings. We know in the past, pharmacists, when this first arrived, had to become police officers, which we all know that pharmacists are not trained to be a police officer. We know that these items are putting people at risk. What type of initiatives are being presented at the Board of Pharmacy, and how can we better serve our patients to ensure communication is met across providers?
Thank you, Scott, and thank you for having me. It's a pleasure for me to be here to partner with you guys on, for a solution. As far as from the Board of Pharmacy, we've been involved with the process for a few years now. It was back to when there were pill mill problem, and even 10 years before that, there was Board of Pharmacy rule and a corresponding rule, I believe, with the Board of Medicine and Board of Osteopaths, that it was corresponding between the prescribing of controlled substances for pain and the dispensing of controlled substances for pain. So I think about 2 years ago, we ran into a situation where, as Josh said, legitimate patients weren't able to get their medication. So it became an issue. I think people thought that rule was an output of the pill mill situation. But as I said, that rule was really in place about 10 years before that. So 2 years ago, we got together with multiple boards and experts. So we had Board of Pharmacy, we had pharmacy associations, medical board, osteopaths, pain specialists, associations associated with each group, DEA representation from major chain pharmacies and from wholesaler distributors as well. And we tackled the issue. We wanted to see what the Board of Pharmacy can do. So one of the things we could do was that rule. And as a result of that rule, we took a little bit of a look at it. We made sure that it was updated from the 2000 version to the 2015 version. And with that was an addition of a continuing education requirement for pharmacists related to controlled substances and dispensing of controlled substance, validating a controlled substance prescription. So one of the pieces of that puzzle was primarily education. It was education across the board. I think, to be honest, the beginning parts of those joint meetings were a little bit chilly. I mean, there was a little bit chilliness back and forth. We had input from patients, pharmacists in the field, a prescriber community in the field, as well as representatives on the boards or on the panel. And it was a lot of finger pointing, and we eventually got beyond that to work towards a common process of what the Board of Pharmacy can do. So a piece of that was completely educational driven. So it was educating each other on the challenges that we were having in general, the challenges that we were having with each other, the challenges that we may have with the DEA, challenges that there was just interpretation issues between the prescriber community and the pharmacy community. So I think we took those initiatives. We came up with a better rule, a more usable rule for practitioners, a fairly clear rule. And so I think it was beneficial. I think the continuing education was crucial. And now we sit at the table again, as Scott mentioned. We actually have a multi-board meeting tomorrow. There'll be representatives of more than just the boards I named. Every board from, literally pharmacy, medical boards, chiropractic, dentists, to learn, nursing boards, to learn different best practices from the different communities that are affected by the epidemic. And I think, it's a repeated education of how we can work together. I think a piece of that is that the board is working on, as well as trying to work with the different prescriber community, is to understand how we can take the really good partnerships that exist in institutional settings between healthcare providers and see if we can, make a similar, process in the community setting with all the touch points that we have. And so we're trying to work on that, get our heads around it, see what we can do and try to work, together. But I do think, I repeated it several times, education has been the key, whether it be educating our individual providers. I had the benefit as a practicing pharmacist to work in hospice for a little bit before I did a majority of my community-based practice. And so working with the patients in hospice, working with the different high doses, working directly with the prescribers, having them on the phone and understanding the pinpoint control that they were looking to achieve with these particular drugs made it a lot more I thought it was a lot more beneficial to me when I went into the community setting to see that every patient that came in with these type of medications wasn't a bad patient, wasn't an addict, didn't necessarily have a problem. They were another patient that you needed to treat, individually, and then work with that provider accordingly, and as needed. And I think that educational experience for me, even though I got it through the workplace, was just so eye-opening that the DEA wasn't going to come in just because I was working with the patient on some type of high dose. The doctors weren't going to be offended by my phone calls or my communications, and the patient was going to end up in a better result. So I think that's what we see the Board of Pharmacy and the other boards of health in the state are working towards. Again, literally tomorrow, in Orlando, there's a big meeting, and we're starting off again and working towards it. And then I guess lastly, we have a specific controlled substance related committee at the Board of Pharmacy made up of consumer members as well as pharmacist members to try to continue to stay on top of the process, learn as much as we can, and see what we can do, whether it be working with our associations, other boards, or the schools to try to just get our hands around the broad scope of the epidemic.
Thank you so much, and I appreciate you honing in on education, because I think we've left our patients out too much in the past and have ran it more so like a business rather than a patient-centered model. Dr. Swartzon, I have a complex question for you actually, but you have a very complex practice. You go from primary care to treating some of the most fierce athletes in the world with the Miami Dolphins. I'm a big fan. Sorry, everybody. But you have a major role. You see patients from the common patient that we hear about, Johnny skateboarding, broke his leg, to an athlete that you described as no different than a patient coming in from a car accident because they get hit at such velocity. If you can describe to me about your approach to pain and the initiatives that you've taken within your own offices to make sure that patients are not just leaving there with a pain pill, because I think many of the things that you spoke to me about were the behavioral side to it and losing that identity. So if you can, please describe that a little bit.
One of the joys of being a physician is you get to know patients, and so each patient should have somewhat of an individualized treatment plan that involves many aspects of medicine, and some of it may be pharmaceutical, but there are other options. So when someone comes in for pain because they had a recent injury, you take into account what the injury was, what their age is, what's going on, and you have a discussion with them. How is your pain now? Because you would think that someone that comes in with a fracture is in a lot of pain, and anyone that's had a fracture knows it's extremely painful. But you also know that once you set that bone and you're in the right cast or the right brace or you're in crutches, your pain shouldn't be that bad anymore. And really, that pain should be a reminder that you have a problem and you shouldn't put weight on it, and maybe we shouldn't mask your pain with a pain medication. There's other ways to treat acute pain. Physical therapy is very, very helpful. There are ways at home, such as ice and massage. We constantly employ non-steroidal anti-inflammatories like ibuprofen. Tylenol, acetaminophen works very well. But one of the other aspects is if you get a young high school player that gets injured and their whole identity is their team, or a professional athlete, that their whole career, or someone in the community that has a job that they now can no longer perform because of their injury, and you give them access to a medication that may have some addictive properties, they may use that as an escape. And so it's important that everyone on the treatment team, whether it's the physician seeing the patient, the physical therapist, the social worker, everyone kind of needs to be aware, even the family, that this person's going to need support, and simply giving them pain medication to cover their pain is not the right answer. There's many alternatives, and quite frankly, I rarely find the need for opioids in regular practice.
Well, one thing you excited me about was how you spoke about the fact that you use genetic testing in parts of your practice, depending on what patient it is, to ensure that the right medication is being used for the right patient, which I commend you on that as well.
There's several panels that are available, and so if I will get someone with knee arthritis and they're not ready for a knee replacement or not a candidate, and we're trying to manage their chronic disease, opioids are not my preferred medication choice. There are other options, and there are tests that are available that can look at how you might respond to a certain medication. It's quite possible that some reasons why people get addicted to medications is simply they don't metabolize it well, and so they require a lot of it, and the typical prescription is too much for them. Or maybe you gave them something that produced toxic levels. What if I knew that beforehand, and therefore I wouldn't prescribe it? And so I do think that pharmacogenetics in the future should be able to help us tailor everyone's treatment plan to personalized medicine. And there is a chance that that will help some of this situation, for sure.
Thank you. Dr. Mai, you were a huge advocate and a voice when other public health issues have arrived, like Zika. What I want to get into a little bit is the needle exchange programs. We spoke about it on the last panel. If you can, tell us a little bit about it from your perspective with your research, the microbiology, the spread of infection, and how these could be prevented through various programs.
Very good question, and actually it's a multi-layered answer to that. So I'll start out by reminding the audience of what Special Agent Jonathan said. 1.4 million Americans will be addicted to opioids, or just this year alone, and the majority of them are in their teens and 20s. This is also the age group that shows very high-risk sexual behavior, which opens them up to infections with HIV, viral hepatitis, STDs, and you add the layer of opioid abuse, and then you have further infections such as wound infections, tuberculosis, things that can go into your heart, cause infective endocarditis, and actually cause deaths. So we know infections can be caused. There are bloodborne pathogens that can be passed along by sharing needles. So the needle exchange program is exactly what it sounds. Provide needles, fresh sterile needles, so that the users of these drugs will not be sharing needles and consequently passing along pathogens. But that's just one approach. And we cannot use federal funds to provide needles. So in addition to needles, there is a very comprehensive integrated approach to providing and delivering various services. So the ideal, of course, is all of these various services can be provided in one place. And these services have to include also substance use, I want to get the name right, substance use disorder and behavioral treatment. Studies show that if we don't address that, we circle back to the exact same problem. So the gentleman mentioned how this should be treated as a chronic condition. I agree completely with him. Things such as diabetes, that's a chronic condition, and there is follow-up. We should have the same with individuals who are addicted to opioids. So the integrated approach, which the needle exchange program or the syringe services programs espouse, include delivery of needles, behavior treatment, linkage to diagnosis of any of these infections that I'm talking about that also potentially have consequences out in the community. Because these users are maybe in sexual contact with other users and non-users. They're sexual partners, for instance, who are not addicted to opioids, but now are impacted, and sometimes for life, with something like HIV. And then you layer in the cost. A fair percent of these addicts are also uninsured or come from low-income households. So who bears the cost of covering these or treating these infections? Hep C, for instance. In 2014 alone, that's hepatitis C virus, we had 30,500 infections. About 50% of those were linked to opioid use and risky behavior, opening them up to hep C infections. The cost of treating hepatitis C, $94,500 for one person. That's in the United States. So who's going to bear that as well? So we can look at it from a public health point of view, but we also need to look at it from a financial, fiscal point of view.
So we're paying a lot of money, which we spoke about from the Appropriations Committee aspect, and a lot of it is our taxpayer dollar, which we could be doing preventative care and actually saving some of that money.
Yes, yes, exactly. There's a study that was done in Australia where they showed that for the student service programs, you spend $1 for prevention as opposed to spending $4 when you don't do prevention, and now you have to treat.
I like 4 versus 1. Dr. Lynch, is going off of this, Jackson was actually a major mover when it came to implementing the exchange program to begin with Dr. Tukes and the research behind that, which it all began, or became. I know you guys also have worked with the medication-assisted treatment within Jackson. You guys have a great thing going, and I know you're developing a lot of programs to make sure that Jackson's a one-stop shop, similar to what we would hope the veterans kind of model would be. Other than financial requirements, what do you feel other facilities can do to take on these major public health issues the way you have? And what do you believe, and do you believe that one-stop shop approach is the future of healthcare?
Yeah, absolutely. I mean, in short order, if you can house all the services that are required to treat these individuals or intervene on their behalf, then it makes perfect sense to not send people out where you're going to lose them to follow up. So it makes perfect sense to house it in one environment. I think part of addressing public health issues is obviously education, but that's been, I think, said probably too many times already. I think unless you've been living in a cave for the last couple of years, you don't know that there's an opioid crisis, so I'm not sure that you need us to be up here telling you that there's a problem in the country. But I think the next step is what to do about it. And you heard some of the people on the last panel talk about a multifaceted approach, and it obviously has to be that. I've had a number of conversations over the last few months about people frankly coming up to me and telling me that I'm the reason why, not me personally, but medicine, doctors are the reason why we have an opioid crisis in this country. And if we just stopped prescribing, then somehow, and sprinkle pixie dust, I guess, then somehow magically we wouldn't have a crisis. And in fact, that's a little bit myopic in its view. I mean, we don't need to point fingers at all of the people that have played a role in here. Certainly we as physicians have played a role. I'm not sure that it's the only role. So I think bringing a number of people who have a vested interest in addressing this problem, who can address this problem from the different facets, like the DEA or the legislation or pharmacy or physicians or the industry, or the CDC for that matter. I think that all of these people working in unison, which is I think what the gist of the last panel was, that's really going to address the issue. So it's not so much that we need more education. I think it's that we need more intervention, that the intervention needs to be broad in its base, and it needs to be somewhat targeted. I go back to my comment before. If you look at the data, Representative Duran, if you look at the data, the bulk of the people that are taking opiates do not represent the bulk of the people prescribed them. So it becomes a very challenging thing for you to craft in a bill that we're only going to target the top 10% of users when they're consuming 70% of the opiates on the market. I get that. But I think it's this broad-based approach. So I do believe that the way to solving a public health issue like this is going to involve a number of players, because those are the number of players that had a hand in seeing this to where it is today.
Thank you. Absolutely.
I'd like to piggyback on that. Dr. Lenches, I agree with you. I think education is great, and we are getting that. I also want to add that we also need to educate our healthcare providers so that they can recognize at first contact with the patient if they're engaging in risky behavior and potentially leading to addictive behavior. I think that's necessary.
And I agree. And many of the meetings that we've gone to between the FMA, the Board of Pharmacy, Florida Pharmacy Association, and others, big thing is not being complacent. And so I think that message being portrayed to the entire profession of whichever profession it's speaking to is very, very important. We need to be engaged as providers and step up for our patients, and I like the way the direction's going now.
I'll just add one other thing, and that is I know that the next panel has patients on it, but I'll just mention that those are people. Each one of us at some point in our life is a patient, and these are the people that absolutely should not be overlooked. The data is riveting to say that most of the people that use opiates get them from family and friends, and they are not the ones that the people who are using it are not the ones that are prescribed this medication to start. So I understand about ratcheting the number down and not having these hang out in your medicine cabinet. Absolutely, but some of this education process is obviously some of the people that are up on the panel and the panel before us. But most of the education process is, hey, listen, just because your friend down the street broke his arm, just like you broke your arm and you got an opiate, that doesn't mean that the guy down the street should get an opiate. That's not exactly the way that it works. And I don't think that in general people do this with any malicious intent. I think people are generally trying to help. Hey, listen, Mike, I know that you're hurting. I have some of these pills left over. They're probably expired anyway, but I still have them. And, I'm going to give them to you. This may help you. I mean, those people probably are legitimately trying to help. Unbeknownst to them, they're fostering this real crisis. So education starts with the consumer, but it goes all the way up the food chain.
Do you? And you said it earlier, but you strongly believe then we, as providers, need to ensure that our patients know just because it's coming from a provider, that doesn't make it safe.
Yeah, without a doubt. I mean, absolutely, we should be writing prescriptions, especially with the DEA in the audience. The only prescriptions that are written, are obviously for legitimate purposes, of course. But I think that to that point, I think how much we give people because your insurance, you only want to have one copay this month instead of having 10 by getting a prescription every 3 days. I think that some of that education has to be that, yeah, you're absolutely right. Despite what I'm giving you, that there's a prescription behind this and it's a legitimate reason that this has a real potential for addiction. It's not my intention to write you a prescription to get you hooked on anything, but it does have a real potential for addiction. We know that. It's a pharmacological property of the medication. You have your own individual genetics that may predispose you to that. And that's, I think, where the science behind limiting the duration that we prescribe or limiting the number of pills that we prescribe within a prescription, I think that really bolsters that.
Thank you. And Dr. Massaros, many initiatives have been made on the pharmaceutical side. I know that CVS has come out with a limiting of prescriptions for the opioids, and Walgreens has also come out with a new protocol that if they're giving more than 50 milligrams of morphine equivalent, that they'll offer Narcan. So we're starting to see a lot of these initiatives be put forth. I'm wanting to know what is being done in terms of policy and what the Board of Pharmacy, what kind of concerns the Board of Pharmacy is raising to ensure that we continue to work with our corporate partners on this effort and we continue to raise this discussion.
I mean, I think it goes back, we look at it from the practice perspective. We also look at it in the Controlled Substance Committee. I think it continues to be about collaboration and communication. I think they're, similar to what Josh said about, giving your neighbor your medication. I think the companies, I think the, independent pharmacists, the PBMs, the payers, the health plans, I think they're trying to attack it like we are. I think they're coming from a good place. I don't think, that the PBMs are putting edits in the POS system to, practice medicine or practice pharmacy. I think they're trying, that's their effort to try to solve, try to solve a problem. So I think I think there's that piece of it. I think, in terms of working, some of the policies into practice, I think there's a lot of news out there about different processes, different companies, different pieces of this puzzle. But I think to actually get it into process, I think it is about how it impacts, how it's going to impact the patient, how it's going to impact the people on the front lines and of pharmacy, whether it be literally across the board. I think pharmacy is developed into a ever-evolving practice. I think pharmacy is trying as a profession to get away from associating it just with the dispensing and more to the clinical piece. So I think those efforts are coming up against, I'm not speaking specifically to Florida, but in general, they're coming up against antiquated laws, at the Board of Pharmacy, and at the risk of offending some folks, at the DEA as well. There's federal laws that take forever to change, and there's pharmacy laws across the country that take forever to change. So, I think that in terms of all these different ideas, getting it into practice, getting it into law, and understanding how each practice setting right now could be vastly different. I mean, we have mail order pharmacy that is meeting the needs of a large percentage of the patient population. You have community-based, you have long-term care, hospice, home infusion. There's various, multiple different ways that pharmacy is being and controlled substances are going to different patients in the state of Florida and from the state of Florida around the country. So I think the Board of Pharmacy is looking to take it and not, to steal a line from earlier, not to paint a broad brush, but to really understand, how the individual practice is evolving, what the role for the individual practice sites may be, and to be open to technological solutions in terms of getting the information out there, whether it be about needle exchange, whether it be about patient counseling, or whether it be about pointing the patient in the right direction like we're talking about. There's a ton of touch points. We know that in the state of Florida in terms of pharmacist community and the pharmacy community. There's independent and, retail grocery store pharmacies all over the place, some areas literally on every corner. But it's, I think, getting that information when that patient comes into that touch point, and then how that information gets to the people on this panel, how that information gets to United Way in a safe and privacy considerate point of view, and how they get, if it's a needle exchange program, not just to educate them on, either the multiple pieces of that. Okay, if you are an addict, this is how you safely dispose of needles. This is how you safely exchange them. If you're not an addict, but you're buying them for some other, lawful reason and healthcare reason, this is why you're getting a pamphlet that says how to do these things, and this is the fiscal impact. There's all those pieces. But then, what do we do with that? Do we just send them out? the door of the pharmacy? In some areas, do we hope that they buy something on the way out, or do we hope that their next stop is Jackson? Do we hope that their next stop is their provider's office, and to be able to complete that circle? So I think we're from the board perspective, we're open to that. We're open to the, whether in 2017, 2018, whether that message is delivered by Twitter, whether it's delivered by scanning your prescription on your prescription bottle on your phone, and you get a pharmacist, or you get access to information right there that you can mobilize and utilize. Whether it's patient counseling through the availability of a pharmacist in that setting, face-to-face, or whether it's a more comfortable environment for you to go home and contact the pharmacist over the phone and be able to get that service. I think that's what we're looking at. I think from a personal perspective, and not being an expert in that area by any means, is we know that there's a lot of MTM offerings out there, that there's programs tied to star ratings, there's programs tied to the impact that pharmacists could have working with other providers. Is there an opportunity to have that same type of program for pain? Is there that opportunity to have it for addiction? Is there that opportunity? I don't know the answer to that. I don't know the resources around that, but is that something that we should be investigating, that those type of programs are in place to be able to get that information to our prescriber community so that they have the information that we have with all those touch points?
Can I get a commitment from the Board of Pharmacy, hypothetically, that you guys will take this effort to ensure that there's education despite the pressures from the corporate entities, that you'll make sure that our patients are going to be educated and have the right educational points around these higher risk medications?
Yeah, I think we are committed to figuring out to make sure that the best people are getting those answers in the way that we just had to parallel it to the controlled substance education piece we had last time. Different people learn in different ways, and it was discussed at the last board meeting, and some people said this educational CE must be live, and other people said it's 2017, we don't do anything live anymore. And then I said, to be honest, I did something like 87 CE for the last cycle when you need 30. I said the two most meaningful ones I did actually were the ones that I did that were self-paced. The FMA coordinated immunization program. I think it's 3 hours. It probably took me 7, but at the same time, I was able to learn it at my own pace. I was able to get all the educational value about it. So I think that's important, is that the individual patients, not only are they are just that, they learn in different ways. I think and so we're committed to figuring out how to get those patients in whatever setting that the pharmacist is practicing in, as much information in their hands as they can get in a safe and effective way. One of the pieces, not to belabor the point, but it was talking about medicine cabinet surfing. And so one of the things were, what if we put a special label on it? What if we put a special label or a special cap or a special color on the patient's medication when they come into the pharmacy? And so it sounded like a great idea. This is dangerous. Let's put a Mr. Yuck. Let's put a red sticker or something on it. And so then some other cynical people, probably including myself, said, okay, but now everyone knows when they go into that medicine cabinet which one to grab. The guessing is literally over at that point. What it also does as well, and here was a concern, because one thing that may be a little bit unique to pharmacy is pharmacy robberies and safety of the patient or the pharmacy provider in that community. If you're at the counter and you're having a lengthy discussion and all your papers are red, because we know that the pharmacy space is pretty open, then does that make you a target walking out the door? Versus my Synthroid that's in a white bottle, now I got the Mr. Yuck sticker, now I got the red sticker. Does that make it a target for, and that makes it more difficult for the DEA, that makes it more difficult for law enforcement, and that makes it dangerous for, for the patient. And that's, something we considered, and, again, it's a struggle. There's many different facets of this, so we're trying to consider all of those and be as practical about it as possible.
Thank you. For Dr. Swartzon and Dr. Lynch's, we understand, and from both your perspectives, and I think in general the consensus would be that the bad apples have created this false silver bullet, this idea that we need to jump in and have a solution right away. There's now been the DEA's recommendations, the CDC's recommendations, different legislation being put into place. How have these regulations created lack of autonomy for both of you in your own professions? And what type of fear has it created from actually treating that compassionate patient? And do you feel that the pharmaceutical companies actually mislabeling their studies, and many people say lying, do you feel that has created some of the barriers as well to actually practicing at your full potential?
I'm a pretty young physician, but even when I started training, the way we look at pain and treating pain was much different. And when I started, opioids were prescribed very, very freely and easily. Patients would call the on-call pager at the hospital at Saturday at 4 in the morning and say, I ran out of my prescription, I need you to call it in to a 24-hour pharmacy. This is a patient I'd never met before, but it's my responsibility covering the clinic to try and sort it out. And before we had an electronic medical record or a prescription monitoring program, I had very little resources with what to do. Now, the fact that I can't call those medications in gives me a little bit of a safety net. I can tell them, I'm sorry, I can't prescribe that medication over phone. This is something that needs to be done in an office visit with your physician. And that puts a lot of the responsibility on them. And part of it should be, if you have a prescription that's running out, it's up to you to get that filled at an appropriate time. And 4 a.m. on a Saturday is not an appropriate time. So part of this comes with experience. You work in the hospitals and in residency, and you give these medications out, and you see they don't last as long as they necessarily say, and you see how some people take 1 pill and some people need 3 pills, and some people it lasts others, and there's a large variation in the population. So experience helps. You know, you were asking me earlier, you know, how I spot someone or how I discuss side effects, and it was only through experience seeing people come in that you start to get it. And now that I have a fellow and residents and med students that come with me, I discuss it with them and I give them my knowledge and experience so that they can not make the same mistakes that I did and try and avoid harming patients, because as a physician, it's our obligation to understand the risks and side effects of all the medications we prescribe. Special Agent Wade, you'd be happy to know I have my CDC prescribing opioids for pain.
You always have that on you, right?
Always have it on me. But this is helpful. This was mailed to me. I didn't ask for it. It was just mailed to me. I look at it. It's very clear. Of course, I got probably 100 emails from different societies mentioning all this, but it's very helpful for someone that maybe needs a refresher. And we have CME where people get refreshers, and in my opinion, anyone that prescribes opiates should, in and of themselves, go and get the education regularly, whether you mandate it or not. They should have that obligation. And if it's not something they know how to do, then they should be referring it to someone else, like a pain clinic, to manage that person's pain appropriately.
And from the perspective of the fear that is present, I mean, amongst providers we spoke about, how has that caused a different pattern of prescribing and or created less autonomy for the practice to begin with?
It's very difficult to have sometimes that conversation with the patient that has been prescribed it before. You know, I'm listening to rules where they're saying that maybe there'll be a 3-day limit. Again, I'm not a high volume prescriber, but I can see a scenario where now you're requiring very, very frequent office visits. I can see more regulations where you're required to log in to websites, and now you're adding to the physician's administrative burden and taking more time away from patients. So, you know, as a physician, you're supposed to know the patient and discuss it. I think with more education and collaboration, it's very helpful. And once the public knows more, which I think they're getting it becomes a lot easier.
Dr. Lynches?
Yeah, I think there, obviously there's going to be fear. You know, people do not want to pop up on the DEA radar because they're the guy that the Wall Street Journal writes about as the #1 prescriber of opiates in the state of Florida. You're guaranteed to get a visit. I imagine Agent White will come and send his people down to come have a conversation with you. So I think that there's absolutely a fear, and it goes to the point that I said initially. I think there's going to be, you know, collateral damage. It's kind of interesting, though, when you look at the history of this epidemic. If you go back, you know, in the 1980s, Nancy Reagan was touting, you know, just say no to drugs, and she wasn't talking about opiates in the 1980s. She was talking about illegal drugs, and as you push the balloon on that side with things like heroin, there was no carfentanil back then, but when you push the balloon on heroin on that side, then it just so happens that in the history of drug evolution in the 1990s, companies like Purdue come out with OxyContin. It was released in '96. But before that was released, there were 2 seminal papers, both of which would fail scholarly productivity at this point in time. One was a case series of 38 patients that was published in the New England Journal of Medicine, among all places. I'm sure they've issued a retraction in the 30 years since that's been published, saying that people who take controlled substances are not going to become addicted. And then there was another horrible case study that had thousands of patients that looked at chronic pain, not in an outpatient setting, but in an inpatient setting. And again, it said that the addictive potential of these drugs was irrelevant. And when you fast forward, you know, that sort of built the industry. So OxyContin comes out in the mid-90s, and then that goes on to be a multi-billion-dollar drug. You get the Federation of State Medical Boards and the Joint Commission that tell you that, and the American Pain Society that tell you that the pain is the 5th vital sign. And now we were actually going to get financially penalized if you did not prescribe enough opiates to people. And then here we are, you know, you fast forward 10, 15 years, and now everybody's saying, well, wait a second, you know, where did this come from? I mean, the whole world sort of brought this on themselves. I mean, there's still HCAP scores to this day that ask you if the patient is satisfied with the amount of pain relief that they're getting. Now, nobody knows that CMS is not tagging physicians for that question this year in 2017, fiscal year 18. And in next October, that question's going to go away altogether. But when you ask, is there a fear based on what all of these individual regulatory agencies and groups are doing? I think it's more of like guilt. You know, they've been pretty complacent at the wheel because everybody has been sold this bale of goods. It's not just the industry that got tagged for a couple $100 million because they were found guilty of misbranding. They were a player, but it's more than that. You know, it's all of these people. Unfortunately, I do think, like I said initially, there will be patients, legitimate pain patients, who have a legitimately written prescription for a legitimate reason, who go to a pharmacy and try to get that filled, and they're going to be pharmacy shopping because they're going to be turfed around. Pharmacies are not going to be so gung-ho to stock drugs, and they'll hide behind some of these regulations or the fact that some unnamed corporate chain in the center of the state got penalized for tens of millions of dollars during the pill mill epidemic. They'll hide behind that, but the fact is, there's some poor guy on the other end of that's walking around Fort Lauderdale looking for some guy to give him his drugs, you know, that are legitimately prescribed. So I just, look, I'm not against what's going on, and I think we need to work in the sausage making. I'll talk to you after about that. I think that there are valid efforts being made to mitigate the fear that prescribers will have in writing these kind of legitimate prescriptions. No one on the last panel would, I would be presumptuous, but I would be presumptuous in saying that no one on the last panel would say any of their efforts are trying to dissuade physicians from writing legitimate prescriptions for people who have legitimate pain. That said, though, I agree with what Mike said, and that is, and the CDC says it, right? This is what I learned in pharmacy school many years ago, and that is you do start low and you go slow. You can always give more. You can't take it away. And there are other agents that have been around for a lot longer than OxyContin has that are just as effective, if not better, at treating some kinds of pain. So it's not that every kind of pain needs an opiate. We know that there are drugs that are anti-epileptics are great for neuropathic pain. I'm not going to throw opiates at patients. So I think that the challenge for us as prescribers is to, there will be a subset of prescribers that will hide behind regulations and say, look, I'm simply not going to write these medications anymore. But I think that it's imperative upon us up here and the last panel, to encourage people that are still writing this kind of medication for a legitimate reason, that they should do that. If that's what is deemed professionally responsible and necessary, then so be it. Everybody is not, it's not whack-a-mole. You can't like take away all opiates in the country. They do work. They were built to cure, to mitigate pain, and they do work to do that. Now, they have adverse effects that we know about, but it would be very naive for us to leave here and say no one in the country should ever be on an opiate for acute pain, right? I'm not even talking about chronic pain. That's simply false.
Thank you so much. Due to time, we have time for just 2 quick questions, if you can. Yes, go ahead.
Hi, my name is Cheryl Murray Powell. I'm a cannabis law attorney, general counsel for Minorities for Medical Marijuana, in-house counsel for Green Roads World. And in the last panel, we heard that medical marijuana, I would also like to say CBD, hemp-derived CBD, can be used as a remedy for this opiate addiction issue. In the state of Florida, we've recently legalized marijuana based on the voice of the people. But we find that the physicians are the gatekeepers as well as the bottleneck for patients getting access to medical marijuana. So a couple questions. One is, why are physicians so slow to become recommending physicians and go through the training required so that they can recommend to patients who need access to medical marijuana, who may have these addiction issues? And also, the next step is, what type of research are physicians advocating with regards to CBD and medical marijuana relieving these pain issues and being used as an alternative to these opiates that are being prescribed daily?
So it's a novel concept to switch, one addictive drug for another. Marijuana, very interestingly, marijuana has been classified as a Class 1 drug through the DEA since the 1970s in the Controlled Substance Act. And in the last almost 50 years that it's been a Class 1, the DEA has been petitioned. I'm sorry to speak for you. Feel free to correct me or jump in. The DEA has been petitioned several times over the decades in an effort to reclassify the drug. In fact, most recently was last year. There was a sum of 3, I think, attempts to do that. And in fact, to this day, we talk about data. Anecdotes are what they are, but frankly, the data is lacking on marijuana for use in a medical purpose. And I say that not based on any gestalt or shoot from the hip, but I say that based on the information from HHS and the CDC that told the DEA that it shouldn't be reclassified because there's no evidence out there. The information about research, I think the medical community is ripe for research. In fact, the University of Mississippi held the only license in the United States since the 1950s to conduct research on marijuana, and in 70 years has never produced a document that said that there was evidence that marijuana is useful for any medical condition. I appreciate the democracy.
There's plenty of research overseas, and legislatively at a federal level, even though we haven't declassified or reclassified, we have defunded enforcement for the DEA with regards to medical marijuana.
So actually, under President Obama, under the prior administration, he gave an order to the Department of Justice that they should really not be pursuing marijuana. It is what it is. It's still illegal for people to have marijuana despite what the state says. That's why it's called recommending. It's not called prescribing. You can't buy it on a credit card. You can't pay with it for a check. You have to give cash. Pharmacies are not going to stock it and sell it. I mean, there's a lot of hurdles still because of its classification as a class 1. The democratic process played out. It is what it is. I respectfully disagree with Senator Farmer. Smoking anything is not good. Medical.
Thank you. Thank you.
So organized medicine is not going to line up behind that. I'm happy to look at research, and we're enthusiastic that the University of Florida has begun to conduct that. We wait to see what results pan out.
Looks like we have another event to come. Yes, from that side.
I'm Naushira Pandya. I'm a geriatrician and endocrinologist. I've been a clinician for too many decades. I think part of the problem with the opioid addiction is the healthcare system delivery, how it's changed. It's all about efficiency, obviously money, and so physicians are not spending enough time with each patient. They're not getting to know the patient. There's a lot of fragmentation of care. So, you have a heart failure, let the cardiologist deal with it. You have COPD, let's send it to the pulmonologist. You have pain, I'll let your pain medicine specialist deal with it. While I respect those specialists, sometimes it's a good relationship and adequate time spent with the patient that can actually lead you in the right direction and maybe help towards deprescribing and looking at underlying issues beneath the addiction. Thank you.
Yeah, I think to piggyback on that, at least slightly, and to talk about something that Mike said, and it's really also a little bit of a petition to Representative Duran, is that when we have this amount of potential funding available and what we're going to do with it, I think one of the things that we need to do is take a lead from some other states and look at a PDMP program that has interoperability to medical record and pharmacy systems, so that it is a continuous process, so that when a prescriber is looking at it, it is through their normal workflow. It is easy to use. It is available to them. They can make the decisions at the right place at the right time. They don't need delegates to do it. Pharmacies don't need delegates to do it. It pops up in the utilization review system, and it becomes a one-stop shop. It's interoperable. Everybody knows what's going on. So I would encourage the representatives and the senators that are here and that were here to consider that piece, because I think it gets a ton of information in the right hands of the providers and the dispensers that are going to be working with these prescriptions. And at the same time, it was one of those things that I think Kathleen brought up in the previous panel for all of us to reach out to those individuals. I would also encourage the representatives and the senators to reach out to us as experts in the field, or at least people with a common interest to solve this problem. I think that we could be beneficial, whether it be the experts that are sitting on this side of the table or the experts that are sitting on that side of the table that have the experience of what's going on in the field. So I would encourage, and I know that, and it's not to say that the representatives or senators are not doing that. I would just encourage them to point their partners in the right direction, and to ask if there is something controversial, just doesn't make sense, there's a lot of news, to get with the panel of folks like this that work with it every single day and understand perhaps those unintended consequences, and and be able to balance that, leverage that information in the right direction.
So you're pretty much saying that we shouldn't have to hit our head before we understand that we need to wear a helmet.
Sure, exactly.
Yes, go ahead.
I wanted to segue from there into, so that's at initial contact. So when someone is addicted and they show up, it highlights the importance of a good needle exchange program. So you have linkage to care, all types of care that the addict might need, and the patient is not lost to follow up when they go somewhere else.
Well, thank you. We're going to go right into the next panel, but I want to give a round of applause to our medical panel. More questions will be answered. Thank you, guys. Thank you so much. We're going to bring up Dr. Trujillo. Please stay with us. We're going to be finish soon, but we have a great final for you guys. All right, we have Dr. Trujillo from Banyan Health. Dr. Trujillo is a psychiatrist, and we're going to get a little bit into the behavioral side. Unfortunately, Mr. Louis Bossi is not able to join us tonight. He was having a bad heart condition and is now in the hospital. So we do apologize for him not being here, but we are going to get a little bit into the behavioral health side and also addiction. If you guys could just quiet down, please. Thank you. So, Dr. Trujillo, talking with you a little bit more about the behavioral health side, I guess the first question to ask here is addiction a disease, both a disease and a behavioral health problem, and can you explain the substance use disorder?
You have asked me the easiest question to answer. I'll address the initial one. Is the addiction a disease? Yes, it is actually a disease. I've been listening to people talking about addiction and being hooked on drugs and so forth and so on. And there is a thing that is called receptors in our bodies. And if you do not have the receptors to the specific drug that you get hooked on and you become addicted to, you are not going to respond to it. For years, we have been conducting research on patients, and I personally had the experience of having a number of patients in a big old tank with cocaine and heroin. We actually provided these drugs freely to both parties as part of the study from the National Institute of Drug Addiction many, many years ago. Patients who actually had the receptors to the heroin, the opiates, went for it. Patients who had receptors to cocaine went for it, and they did not mix it. So it requires a receptor's presence for you to have that. So basically, if you have an epidemic with opiates today, is because somebody prescribed this medication, or somebody got this drug on the streets, or somebody just shared a needle and exchanged drugs, and the particular patient that is becoming addicted and is becoming the focus of attention and treatment had the receptors to respond to the specific drug. That is what makes the basis for this condition to be a disease process. Patients sometimes don't have receptors for a particular drug, but those who do have the receptors actually have a very high potential of becoming addicted, and they cannot stop once they actually start to do it. There is a genetic loading. We have seen genetic loading in alcoholism. We have seen this in bipolar disease, in schizophrenia, in many psychiatric and substance abuse conditions. So it is a disease process. How do you determine this? By doing PET scanning of the brain receptors. This is why we have today the proof of being able to provide MAT, medication-assisted treatment. If you have the receptors for opiates and I inject you with a medication that is going to block these receptors, basically naltrexone, and it's going to be in your body for the next 30 days, there will be no attachment. Therefore, the cravings for the drugs decrease. Therefore, the drugs, if you decide to use them, are not going to be tied or attach themselves to your receptors, so you're not going to continue to experience that pleasure principle.
So you talked about genetics, and I know that there's not a gene for addiction, but more so we relate it to a cluster of genes.
A cluster of genes.
And also, we know that individuals with this cluster of genes can be addicted to basically anything, not just opioids itself, but the fact is people that have that percentage could be addicted to marijuana, for instance, or in other activities.
What you have is the perception that addiction is just a pure to one substance. It's multiple substance abuse is led because there is multiple receptors to different drugs. I hear people discussing the substitution of marijuana for opiates. And I have to insist on the following fact. There is no substitute for a clinician's experience to work with these patients. If this was indeed a correct statement, every single patient that I detox, and I detox an approximation of between 8 to 10 patients addicted to heroin or opiates on a daily basis. I have done over 935 cases on this year just alone. For every single one of those patients that I do a drug screen when they come into my crisis unit asking to be detoxed because they are sick and tired of being hooked on the drugs, and I have a result positive for cannabis, positive for benzos, positive for heroin and opiates, positive for amphetamines, then marijuana did not stop the desire to use. Now, this does not apply to 100% of the patients. There might be some in which they respond. We have a society of patients that come to doctors every day, and they actually walk into my office because of the advertisement by pharmaceutical companies. Dr. T, that's what everybody calls me in this community. I want you to prescribe this for me, because that is what I need. I have pain, and this is the only thing that works for me. I have had patients with dual diagnosis come in and demand that I prescribe marijuana for anxiety. It is not indicated for the treatment of anxiety, so I'm not going to prescribe it for you. Many times, it is a matter of reality-orienting your patient to the fact. Most of the time when I have a patient that demands drugs that are controlled substances, I usually come back to them and I say, no, I am not going to prescribe it for you because it is not indicated in the treatment of your psychiatric or addictive condition. I have 2 words for you. Michael Jackson. He told his doctor what to prescribe, he died, and the doctor went to jail. It's not gonna happen, not on my turf, not on my watch. But many times we are in a society in which we have this additional pressure to prescribe what is unnecessary. I have patients coming into my crisis emergency room with a little prescription from the ER, on OxyContin, for a 3-day supply. And this is what the doctor prescribed for me, so this is what you have to continue to treat me with. Dude, I just did a drug screen. You have morphine, heroin, marijuana, and methamphetamines in the drug screen. No, I am not going to prescribe a controlled substance to treat you. I am going to detox you and try to get you into a medication-assisted treatment because this is a new thing that we have available today. I started practicing addiction back in 1980, 82, 83. At that point in time, we had a tidal wave of people with heroin addiction, IV drug abusers. I saw the people in the community say, this is a choice problem. Then in 1983, HTLV3, what we call today HIV and AIDS, came into place. Guess what happened to many of my patients? They were doing this because they were gay, they were doing this because they were drug addicts, and it was not a disease process. Most of them died. There was no way to really help them. What I see today is a tidal wave of people not in the gay department, not in the substance abuse department, but people with common pains and aches that continue to actually trigger the receptors' occupancy with opiates and become addicted to it and cannot give it up. But this is trickling to our children. The families are being destroyed. We're burying our kids and our adolescents because they go into the medication cabinet, and it's got to be a stop to it. And it is happening because it is a disease, and it needs to be addressed as such.
Thank you. And I spoke a little bit about the centralized holding unit and how many patients or people that are involved in crime and so forth, but they have to do with behavioral health, addiction, and so on, get put through this process. And I know Henderson has been a great partner, and they many times end up in your treatment. So can you tell us about that approach, if that's what we've been talking about, silver bullet to tackling this issue, and how do we get rid of the stigma of mental health?
Getting rid of the stigma of mental health starts by actually openly discussing the fact that it exists. There is absolutely, positively, not a single human being on the face of earth that is not going to experience a depression when you lose a loved one or your pet or someone. Everyone is going to be affected by it. But there is a number of psychiatric conditions, such as bipolar disorder and schizophrenia, which come in with addiction problems. They have a tendency to use or abuse substances that are controlled substances, and this is what we call them the dual diagnosis. The centralized receiving facility that Henderson started here, I am starting as of November 13th in Dade County as part of Banyan Health Systems. And one of the things that we do is the following, and this is just plain common sense. Before I became a psychiatrist, I did internal medicine. I used to work at JMH in the medical ER. And if I had a patient that walked in with a broken arm and a broken leg, I will not just cast the leg and say, come back in another week for me to do the arm. If I have a patient with a dual diagnosis, a psychiatric disorder and a substance abuse disorder, it needs to be addressed, both of them. But that is not the only situation that we're facing today. I have a patient with dual diagnosis, mental health disorder, substance abuse disorder, but they have been using IV drug heroin. Now, not only do they come with hepatitis C, they come with MRSA, they come with medical conditions, so then you have to address the comprehensive care of the individual cannot be obliterated by the fact that there is drugs. In the past, we used to say, well, if I am not going to treat the psychiatric disorder until the drug stops, I'm not going to treat the drug problem until the psychiatric disorder is taken care of. Again, the concept, broken arm, broken leg, both of them need to be fixed at the time in which this is happening. If you have a dual diagnosis with medical conditions, it all needs to be addressed within a comprehensive approach to care, and this is what centralized receiving facilities are actually developing to take care of.
Well, we know in the past behavioral health has not been on the hot topic, and it should be. And treatment needs to be of great importance, so what you do every day is amazing.
And does anybody know what happens to somebody that comes in for detox? Number one, they're giving up their drug of choice that makes them feel good. Number two, they're going to be detoxified, and they're going to, like I tell them, you're in for a very rough ride. You're going to go into withdrawals. It's not going to be pretty. It's going to be tough. It's going to be difficult. And number three, they become depressed because they no longer getting what they like. So there is a component of depression, even if you're not dual diagnosis, that happens. Then they have rebound insomnia. They have difficulty with anxiety. They become cranky, irritable, and many people do not understand that they are going through this very rough phase. But through the years I have been actually practicing addiction medicine, I have seen quite a few people give up their addictions, stay totally drug-free for 10, 15, 20, 30 years, and I've been doing this for 37 years. And one of the things that I actually are able to see is the fact that they do not want to continue to do this. And once they get the right help and they're placed in the right direction, they can become advocates and peers to help the rest of the team that is actually still using drugs.
And nobody wants to become addicted. And I feel like that is a topic that people feel.
It's not a choice.
Right.
It is you are predisposed by the presence of receptors in your body. The receptors may be dormant, okay? You hear the story, if you're an alcoholic, you're gonna be an alcoholic for the rest of your life. You have the receptors for alcohol. Some people do not have the receptors for alcohol, and you can drink all you want and you will never become an alcoholic. You will be able to say no. An alcoholic takes that very first drink, even if you have been sober for 20 years, and may not be able to stop. And it requires understanding, it requires help and assistance, and it requires for us to try to help them out. The same is happening with the opiates. This is not the first time we have a pandemic of opiates. It's happened before, and it's happening again. I just hope that the thing is that many people are dying. Freely, we are dispensing Narcan to as many people as we can. There is not a single addict that I discharge that I say to him, you have been clean, you're going to a rehabilitation program, take this Narcan kit, and if you see anybody of your bodies using drugs, save a life. The police department is carrying, first responder is trying. We need to give them a choice, the chance, the opportunity to actually get back into the shape of life and things and enjoying life in a drug-free environment.
Thank you. You and I spoke a little bit, and I know many people know my story. I grew up with a very sick mother, physically, and she had mental health disorders as well, bipolar, heart angina, cancer, bouts of cancer, diabetes, neuropathy associated. And she was one of these patients that went from a normal patient going to a doctor before PDMP and everything was involved to an addict. And as a young individual, I didn't know what was going on. I obviously was oblivious to the treatment because my thoughts were that she was going to her physician, she was going to her pharmacist, and that she was getting the right treatment. In 2009, my mom died from an overdose, and I have been working very hard to ensure other family members do not go through the same thing that my family had to go through. It's very important for us to turn negatives into a positive, and I feel that's what we're able to do here. Between all the resources that we've been able to put together through the community response team with the United Way, through the university and training future educators, this is our initiative. This is our hands-on deck approach. Everybody's involved. We cannot dismiss this subject any further. So I ask you, after this event, for my call to action, please be a resource. Educate your patients. Speak out to a friend. And just be vocal about these issues. These are personal, professional, and I believe that we can actually solve them if we all put our minds to it and all put our efforts in. So I want to thank you guys for all coming here tonight, and thank you for all the panelists and for all the special guests. It's because of you guys we're able to put events on like this and truly, truly tackle public health issues. So thank you guys for coming to the United Stand Symposium, and have a great night.
Thank you.